Good afternoon, everyone, and welcome to today's webinar presented by the Lake Superior Quality Innovation Network. The Lake Superior Twin is comprised of 3 organizations: MPRO in Michigan, Medistar in Wisconsin, and Stratus Health in Minnesota, to support the Centers of Medicare and Medicaid Services priorities for healthcare quality improvement in each organization's respective state. So just some housekeeping items. Today's webinar slides are going to be available on our Lake Superior Twin YouTube page within the next week. So I'd like to get started by introducing today's speakers. So first I have myself. My name is Andrea Boucher. I am a Quality Program Manager for our hypertension and diabetes programs here at MPRO. And I also have with me Julie Campbell, who is a clinical quality consultant on those projects as well. So at this time, we're going to go ahead and get started. We will go over our objectives for today. So what we're going to be doing is reviewing some techniques for accurate blood pressure measurement. We have a 10-step process of recommendations for you to follow, and then we'll look at some blood pressure thresholds and understand the different treatment options. And then we'll also be discussing strategies for making hypertension control a priority in your practice. So I just wanted to start out with some stats for you. These are from 2010 from the CDC, and they're the leading causes of death in the U.S. And I highlighted in red those that are related to cardiac and other hypertension-related diseases. So heart disease accounts for about 1 in every 4 deaths in the United States. And patients who have hypertension or high blood pressure, that can lead to a higher risk for stroke and other heart-related diseases. So hypertension control can reduce the excess morbidity and mortality that we can see are the number 1 and number 4 causes of death in the U.S. here. And I have on the next slide a really great infographic on the urgency around high blood pressure control. So beginning with about 115 over 75 for blood pressure, cardiovascular risk doubles for each increment of 20 over 10 millimeters of mercury. And about 50 million Americans have high blood pressure that warrant some form of treatment. And about 30% of those adults who have high blood pressure are actually still unaware that they have hypertension. And some of those could either be misclassified or they're undiagnosed. So 40% of individuals are actually, with hypertension, are actually not receiving the treatment that they need. And that's why we are talking today about the importance of taking a proper blood pressure measurement and classifying those patients correctly. Because every 10-point drop in a systolic blood pressure can lead to a 30 to 50% drop in their risk for cardiovascular disease and stroke. So why is it important for blood pressure measurement? So hypertension means that there's a higher than normal pressure in the arteries, and that pressure can cause further strain on the patient's organs, and that can lead to further organ damage. High blood pressure is obviously a major cause of heart attacks, heart failure, kidney damage, and stroke. And the treatment of high blood pressure can dramatically decrease the risk of a poor outcome for that patient. So that's why we're talking to you about the importance of measuring an accurate blood pressure. And that blood pressure that's taken in the physician office is used to initiate treatment and to really monitor the effects of a drug therapy that a patient might be initiated on. So a missed elevated reading can lead to undertreatment, and that can lead to further organ damage for that patient. And also a false high reading can lead to overtreatment, and that patient could possibly have some drug-induced side effects if they're put on a medication that they don't necessarily need to be on if they aren't a hypertensive patient. So what impacts a patient's blood pressure? There are multiple different factors, and we've categorized them here for you into patient factors, ones that we can't always control, and measurement factors. And these are the ones that we have total control over, and we want to make sure that we're taking patients' blood pressures as accurately as possible to control these factors. So with the patient factors, we'll start with the white coat syndrome. So this happens when a patient has a higher or an elevated blood pressure reading in a clinical setting as opposed to what they see at home. And self-monitoring blood pressure for that patient at home can really weed out those truly masked hypertension patients. So you can see which patients actually have hypertension and which ones are experiencing white coat syndrome. And that also goes in with the next bullet point there with the nervousness and stress. Obviously, patients can feel those types of emotions as they're in a clinical setting, so that can go under with the white coat syndrome as well. Demographics such as age, sex, race, and ethnicity can also impact the patient's blood pressure, but obviously are factors that are out of our control. And then also lifestyle. So looking at a patient's diet and exercise habits, those can definitely have an impact if they have poor diet and exercise qualities that they're looking at, and that is the first line of defense when initiating treatment for a patient is usually recommendations for modifying their diet and exercise routine. And then also looking at substance use. So if a patient is a smoker or they're using alcohol, those can also have an impact on their blood pressure. And then moving over to the measurement factors, these are all factors, like I said, that we can control. And each of these factors are interdependent, and they can ultimately affect the performance or the technique that we're doing to take a blood pressure measurement. Most of these factors are addressed as part of the competency training process. So starting from the top, if you have air in the blood pressure cuff before measuring the patient's blood pressure, that can cause a falsely elevated reading. Also making sure to choose the correct cuff size. So if you choose one that's too large, that's going to give an underestimation of the patient's blood pressure, and one that's too small can overestimate the patient's blood pressure. Also making sure that the cuff is wrapped evenly. If it's unevenly wrapped, that can lead to a falsely elevated reading. Deflating the cuff too quickly. So what we like to say is the slower the better. Usually we like to see it fall at about 2 to 3 millimeters of mercury per second. Also, not inflating the cuff high enough. So you want to make sure that you're not just inflating to a blanket statement. It's more of a patient-by-patient basis as opposed to just going up to 180 or 200 millimeters of mercury for every patient. Because if a patient had a even higher systolic blood pressure, you could possibly be missing where that actual systolic reading should be at. And the oscillatory gap. So this is when the pulse disappears and then it reappears while deflating the cuff. So you want to make sure you're interpreting this gap correctly, and one way to kind of mitigate this or to make sure that you're accurately capturing the patient's blood pressure is to use the radial palpitation technique, and we'll talk about that in just a second. And then the last bullet there is looking at the gauge at an angle. So you want to make sure you're looking at the gauge straight on so you don't get any glare, and that you're also seeing where those proper systolic and diastolic readings fall. All right, so we have some evidence-based strategies for proper blood pressure measurements. One way to make sure that all staff are completing blood pressure the same way on every patient every time is that there are well-developed policies and procedures at an organizational level to make sure that every staff member has met the competency for blood pressure measurement. And that goes in the training and evaluating direct care staff. So one way to do this is through testing competency. We recommend to test blood pressure competency on an annual basis. This goes in with if you have turnover in staff, making sure that any new staff brought on is completing blood pressure measurement in the same way every time. This can be done through external auditors. They can make surprise visits and act as a patient as opposed to teaching it in a classroom type setting. So this is a really good way to assess staff competency in an actual real-world setting. All right, so we're going to start now with the 10 steps for proper technique, And these were adapted from the National Health and Nutrition Examination Survey and also the American Heart Association recommendation for proper blood pressure technique. So step number 1 is to choose the right equipment. So you'll need to make sure that you have a quality stethoscope, an appropriately sized blood pressure cuff that fits your patient, and also the blood pressure measurement instrument itself, whether you're using an automatic or a manual. These 10 steps are going to fall into the manual measurement, but you can choose whichever is best in your office setting. And step number 2 is to prepare your patient. So you want to make sure you're allowing your patient 5 minutes of rest before you're taking their reading. So that's really the gold standard. Obviously, we know you don't have a ton of time to spend with all of your patients, but making sure you try to at least give them a couple minutes of rest before immediately taking their blood pressure. And this is an infographic from the American Medical Association, and it just outlines some tips to get an accurate blood pressure reading, so how to position a patient to get an accurate reading. So I'm going to start from the top right bubble and then move clockwise. So the first one is making sure that the patient has an empty bladder. One way to do this is to take a urine sample if that's necessary on that patient first before you room the patient. Because if a patient has a full bladder, that could add approximately 10 to 15 millimeters of mercury to their reading. Also, you want to make sure you have the patient's back supported, as opposed to putting them right on the exam table. If there is a chair available in the exam room, I would recommend having them sit in that, as long as it has the back support and that their feet are able to touch the ground as well. An unsupported back actually adds 5 to 10 millimeters of mercury. You also want the patient to keep their legs and ankles uncrossed and that their feet are supported on the ground. You also want to support the patient's arm at heart level, so that could be done in various ways, either on the table, on the armrest of the chair, or whatever you or the patient is most comfortable with. And then place the cuff on the patient's bare arm. So if you're placing the blood pressure cuff over clothing, that could add between 10 to 40 millimeters of mercury to that patient's reading. And then lastly is to not have a conversation with the patient, because with the patient talking, not only will you not be able to hear where the systolic and diastolic readings may be, talking also elevates the patient's blood pressure. So all of these factors together can impact a patient's blood pressure by about 50 to 100 millimeters of mercury, which that could mean the difference of a diagnosis of hypertension between having to start a medication therapy or even adjusting doses to the medication that they are currently on. So that could mean a huge difference for that patient. And step number 3 is to choose the proper blood pressure cuff size. So this is where a lot of measurement errors occur. It's because people are not taking the time to choose the proper cuff size. So one way to ensure that it is the correct cuff size is to wrap the cuff around the patient's arm, and there is an index line that falls on the very outer edge of the blood pressure cuff, and making sure it falls within the range, which you will see that as you're wrapping the cuff around the patient's arm. So if it falls within the inside of the range, you know that the cuff is going to be too large and you need to choose a smaller cuff. If it falls on the outside of the range, it's going to be too small and you need to choose a larger cuff. So the next slide, it'll show you the proper dimensions. This is just a resource for you to have. Obviously, it does take a lot of time to measure a patient's arm, but just to give you an idea of the arm circumference range that fits the proper blood pressure cuff size. Step number 4 is to place the blood pressure cuff on the patient's arm. So you want to palpate where the brachial artery is and position the blood pressure cuff so that the artery marker on the blood pressure cuff is pointing down towards the brachial artery. And then wrap the cuff snugly around the patient's arm. And one way to know if it's a good fit is if you can slip 2 fingers at the top of the blood pressure cuff. If you can't do 2 fingers, you know it's going to be too tight. If it's more than 2, it's going to be too loose, and you'll need to readjust accordingly. And step number 5 is to position the stethoscope. So on the same arm where you place the blood pressure cuff, you want to palpate and locate the crease of the arm. And you want to feel where you're going to hear those strongest pulse sounds. And you'll place the diaphragm of the stethoscope over the brachial artery at that location. So we're about halfway through our steps, and I'm going to turn it over to Julie to cover the remaining 5.
So step number 6 is to determine the maximum inflation level, and this is also known as the oscillatory palpatory technique. So like Andrea was talking about earlier, this is what we're going to be able to do on a patient-by-patient basis to make sure that we're getting the accurate systolic level. So we actually have 2 techniques to be able to determine this. The first is to inflate the cuff as you listen to the brachial pulse through the stethoscope. So you'll be inflating the cuff, and when it is enough to block blood flow, you're going to stop hearing the pulse sounds through the stethoscope. Remember that number, and then inflate about 20 to 30 millimeters of mercury above that number, and then go ahead and deflate and take a reading. The second option to be able to determine this level is to inflate the cuff as you palpate the radial pulse with 2 fingers. So you won't be using the stethoscope at this time, but as the cuff inflates enough to block blood flow, you'll note the gauge reading when you stop feeling the radial pulse. And then when you are ready to measure, you'll actually inflate again and inflate the cuff to about 20 to 30 millimeters of mercury above that number. Step number 7 then is to slowly deflate the blood pressure cuff. So you'll begin deflation, and like Andrea mentioned earlier, the American Heart Association recommends that pressure should fall at about 2 to 3 millimeters of mercury per second. And this seems kind of slow, but the idea here is to just make sure that we're noting accurate gauge readings for both the systolic and diastolic pressure. And step number 8 is to listen for the systolic reading. So the first occurrence of pulse sounds heard as the blood begins to flow through the artery is our systolic pressure, and this is going to sound like a tapping noise at first as you hear the pulse. Step number 9 is to listen for the diastolic reading. So you'll continue to listen as the pressure in the cuff drops, and you'll note the gauge reading when the last rhythmic sounds are heard. And then our last step, step number 10, is to double check for accuracy. So the AHA recommends taking a reading in both arms and then averaging those readings if you need to check again. This is also going to depend on what the patient can tolerate, whether you're using the right or the left arm. And then when we're checking the pressure again for accuracy, it's important to give the patient some time at rest. So again, the gold standard would be waiting about 5 minutes. We don't always have time to do that, but just try to give them the same amount of time before that second reading that you did before the first reading. And then typically blood pressure is higher in the mornings and lower in the evenings. It peaks about midday. And so this is just something to keep in mind for when the patient is coming in for a visit, how their blood pressure might fluctuate throughout the day. And then if the blood pressure reading is a concern or you think this patient might be experiencing hypertension, patients can actually be submitted for a 24-hour blood pressure study to assess that individual's overall blood pressure profile and how that might fluctuate for them throughout the day. So those are the 10 steps that we are recommending for manual blood pressure measurement. This next section now goes into diagnosis and treatment for hypertension. So this slide here is based on the CDC's blood pressure fact sheet. It lays out the different blood pressure level thresholds. So you'll see here that normal is being defined as a systolic under 120 millimeters of mercury and a diastolic under 80 millimeters of mercury. Prehypertension here is being defined as 120 to 139 over 80 to 89. Stage 1 hypertension is 140 to 159 over 90 to 99 millimeters of mercury. And then stage 2 hypertension is going to be anything at or above 160 over 100 millimeters of mercury. So when we talk about diagnosing hypertension, there are a couple of different things that we want to do to be able to do this. It's important to look back at a patient's medical history to see if they have multiple previous elevated measures. If a patient has multiple elevated levels in the past and doesn't have a diagnosis of hypertension, this is something you definitely want to revisit to ensure that they have the diagnosis that's necessary and that they're being captured for management and treatment. And then when you're noting an elevated level within that visit, it's important to confirm that diagnosis at a second visit about 1 to 4 weeks after the first visit when you're noticing an elevated level. Also, too, I think it's important to mention here that it's recommended that if a patient's blood pressure is measuring over 120/80 in that visit, that a second blood pressure is taken. So that can be by the medical assistant again, or if the provider would like to take another level just to confirm that it is elevated. And then if a patient's blood pressure is extremely high, so something like a systolic level of over 180 millimeters of mercury, or if you think the patient may not necessarily attend their next follow-up visit, treatment can be started after one set of measurements. This is basically just to capture those patients to begin management strategies before they're lost to follow-up, so that when they're returning, it's not much worse than before. So when we're talking about management of hypertension, usually the first line of recommendations that we're making to patients are for lifestyle changes. So these recommendations here are taken both from the USDA and the CDC. So first we have dietary recommendations. So we want to make sure that patients are recommended a diet that is high in fruits and vegetables and other fiber, also high in protein and minerals, and diets that are low in sodium, total unsaturated fat, and cholesterol. For physical activity, for adults 18 to 64 years, it's recommended that they're getting 2.5 hours a week of moderate aerobic activity or an hour and 15 minutes a week of vigorous aerobic activity. And then also for substance use, if a patient is smoking or using alcohol, we want to encourage cessation as those activities do impact both blood pressure and other chronic diseases. So this next table here is taken from the Million Hearts campaign, and it kind of corresponds with Andrea's infographic earlier about patient positioning. So this table addresses lifestyle modifications and the potential impact that they can have on a patient's blood pressure. So you'll see along the left side are different lifestyle modifications. The first one is weight reduction. And then in the middle column here are recommendations to that lifestyle modification. And then along the right side is the approximate systolic blood pressure reduction. So if a patient is maintaining a normal body weight, that has the potential to reduce their systolic blood pressure anywhere from 5 to 20 millimeters of mercury. So this is kind of a nice educational tool for patients to see too. We're constantly recommending lifestyle changes to them, but if they can kind of see how those potential changes might impact their blood pressure, that can be useful for them. And also, lifestyle modifications might mean the difference of a patient getting their high blood pressure under control and not necessarily having to start a medication regimen. So the next management technique for hypertension is medication management. And we know that this does vary a lot depending on individual patient characteristics. So we just have a couple that are summarized here. So first, a patient's age. It's recommended by JNC8 that pharmacologic treatment should begin at over 150/90 millimeters of mercury for patients that are 60 years and older. And then for patients who are less than 60 years of age, it's recommended that pharmacologic treatment start when it's above 140/90 millimeters of mercury. Demographics can also come into play when we're talking about the effectiveness of medication management. So things like thiazides and calcium channel blockers are proving more effective in the African American population, just as one example. And then comorbidities also have a lot to do with how effective medications can be and which ones we're choosing for them. So patients with diabetes are at increased risk of coronary artery disease, and heart failure. So those patients are known to benefit from ACE inhibitors as well as ARBs. And then we have a couple of medication management practices as well. So monitor blood pressure and adjust the regimen until blood pressure is reached. We always want to check in with patients and ask if they're taking their medications, and then study over a long period of time how those medications are working. And we want to wait about 2 to 3 weeks before increasing a dose of a drug or adding a new drug. And then if their target blood pressure is not being reached within about a month after treatment initiation, the dose of the first medication can be increased or a second medication can be added. And then just as a general rule, it's not recommended to combine ACE inhibitors and ARBs. So this table here lays out the target blood pressure levels for patients based on their patient characteristics. So along the left side of the table, you can see different patient characteristics. So for patients less than 60 years of age, at the bottom, over 60 years of age, and then also a couple of comorbidities, so patients with diabetes as well as chronic kidney disease. And then in the right two columns, we have here just kind of compared for you the recommendations from the 8th Joint National Committee, and then also recommendations from the American Society of Hypertension. So not most providers are using the JNC8 recommendations, which are summarized in the middle. So for patients who are less than 60 years of age, we want to treat them to below 140 over 90 millimeters of mercury. That differs a little bit from the patient characteristic at the bottom. For patients over 60 years of age, they have a little bit higher recommended level that we can treat them to, so about 150 over 90 millimeters of mercury. And then for patients with diabetes and chronic kidney disease, they have a similar recommendation of being treated to below 140 over 90. So if after a number of visits the patient is still not meeting their target blood pressure, we can also consider referring the patient to a hypertension specialist. So this graphic on the right here is taken from the American Society of Hypertension's website, and they have a tool that you can actually type in the specialist that you're looking for and then specify within X number of miles. So that might be set to a number of miles from the patient's home or maybe from their primary care provider office, just to ensure that the patient can follow up with that provider and that they are getting the attention that they need to that condition specifically. Another strategy that we like to recommend for hypertension management is teaching self-monitoring to patients. So engaging them in taking their own blood pressure daily at home using self-monitoring devices. And then we also like to make the recommendation of having the patient record each of these blood pressure levels. They can do that on paper, although some EHRs also have the capability for patients to record that in the EHR or maybe send that via messaging in the patient portal to their providers. And this just gives the provider a better look at what that patient's blood pressure looks like throughout the day. So this can also be particularly useful if the patient is experiencing white coat syndrome or if the patient is a smoker. So they would want to know, like Andrea was saying earlier, within a half an hour of smoking, their blood pressure is going to be elevated. So this gives them the ability to measure their blood pressure kind of after that half an hour window. We also want to make a couple of recommendations for utilizing EHRs to better manage hypertension. So you can use clinical decision support alerts. So based on the blood pressure that's being entered into the system, it can give a notification to the provider so that the provider can implement their blood pressure protocol. You can also use the EHR to set up monthly recall reports. So this allows you to follow up with patients that might be diagnosed with hypertension who have not been in for their follow-up visit within the past 3 to 6 months. So this is something that might allow you to notice the patients that haven't been in for follow-up and to capture them. You can also utilize messaging to patients through the patient portal. So like I mentioned earlier, you can use this for self-monitoring. If the patient has any questions about their condition, they're able to submit it back. And they can also schedule follow-up visits without having to call or come into the office. And then EHR can also be used to track the quality measure NQF-18, which is for controlling high blood pressure, just to kind of give you an idea of how your patient population is doing over time. We also wanted to mention a couple of resources. So the first one on the left is the Hypertension Control Change Package from the Million Hearts campaign. And this kind of goes along with the resource on the right. This one's from MPRO. They are similar in that they make recommendations for hypertension management, and then they also utilize a PDSA cycle, so making recommendations and then kind of guiding clinicians and office staff through how to plan, do, study, and act different changes that they're making and kind of gauge the effectiveness of different interventions. And then the resource in the middle is a customizable blood pressure protocol. This is also taken from the Million Hearts campaign. So like we were talking about earlier, enacting a protocol, you can set this up for how you want it to look in your practice. Online, this Million Hearts campaign protocol is available, and all of the fields that are in red italics can be customized to your specific protocol. So in the upper right hand, or the upper left, corner of this resource, it gives you kind of if the patient is measuring at stage 1 hypertension or stage 2 hypertension. And then if you follow the arrows, it's basically making recommendations for when the patient should be followed up with and what kind of medications are recommended. And then on this slide, we just have a couple more strategies for making hypertension control a practice priority. So we like to recommend designating a hypertension champion in the practice. And this is a staff member that's chosen from their peers that is strong in their blood pressure technique and also is willing to take charge on some interventions that the practice is doing to accurately measure, document, and monitor blood pressure and hypertension. We also recommend care team engagement, and the hypertension champion can be a big part of this, kind of getting everybody on board and moving forward with similar techniques across the board. Also, providing blood pressure checks without appointments or copays. We made the recommendation before for self-monitored blood pressure at home, although some patients aren't always able to have their own at-home blood pressure monitors. Maybe they can't afford them. The office can offer blood pressure checks without the patient having to make an appointment, so in that way they can come in and have their blood pressure checked if that's a concern for them. The next one is to develop a flow chart for how hypertension will be tracked and managed in the practice, so that kind of goes along with the previous slide and the million-part protocol that we just recommended. Also, to train and evaluate direct care staff on accurate blood pressure measurement, so that kind of goes along with what we're doing today, and then recommending that competency is followed up with and checked annually. And then also identify and promote patient medication adherence, and like we just talked about, establish a program to support at-home blood pressure monitoring. So at this time, I think we'd like to open it up to any questions if participants might have them.
Operator, can you please open the line for questions?
Yes, ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Again, ladies and gentlemen, if you would like to ask a question, please press the number 1 key.
And while we're waiting for questions to get in the queue, please feel free to also send them in the chat if you would like to send them that way as well.
There's no questions in queue at the moment.
All right, so just a reminder to everybody, today's slides are going to be available on our Lake Superior YouTube page within the next week. So at this time, we'd like to pull up our evaluation questions. So we just ask you to please take a moment to let us know how we did by filling these out. Do we have any other questions on the line?
Ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Again, ladies and gentlemen, if you would like to ask a question, please press the number 1 key. There's no callers in queue. Questions. Thank you.
Okay, we would just like to thank everyone for joining us today. We hope that you're able to join one of our future webinars, and we will be distributing the recording of this webinar to our email list. So again, thank you for everyone joining us, and please feel free to fill out our evaluation questions. Thank you.
Thank you, ladies and gentlemen, for joining. You may now disconnect. Have a great day.